Welcome to a Medical Associates Health Check. I am Dr. Bristow. I am the founder of the Concierge Medical Clinic, and I'm a specialist physician in internal medicine. And today with me, I have my co-host.
Hi, I'm Dr. Elisha Salvaraja. I am the clinical administrator and head of accident and emergency at Medical Associates Hospital.
And today we are going to be diving into a nice little topic around women's health, and more specifically, uterine artery embolization, which is like a nice little fancy words, but we'll break it down for you into simple, easy to understand language.
So, we would like to introduce you to our guest today. That's Dr. Robbie Rampasad. He's an interventional radiologist. Welcome, Dr. Rampasad.
Thank you very much, Aisha and Christopher.
Nice
So,
one, Robbie.
I know I see it, and I'm sure you see it, but we see a lot of women that come in with painful periods and irregular bleeding. And what else do you see, Chris?
Well, for me, is a very common problem, right?
Yeah.
I mean, I post on social media.
Yeah.
You could go and follow on the Concierge Medical Clinic on TikTok and
Oh,
stuff
just
like
plug
that.
in, just plug.
Yeah. But I actually recently posted about fibroids.
Yeah.
Right. And not so much from a gynecological perspective, but from an internal medicine perspective. I would see the woman when they come in because they feel unwell because of whatever else is going on.
Yeah.
And like, typically the most common features of that is they actually just feel weak, they feel tired, they low energy, and it's because they're anemic, right?
And you see, the thing is, women will have these painful, heavy periods, and they will just, I think maybe it's society, maybe it's cultural, but they will just think it's normal to bleed this heavily,
Yeah.
and they will continue to do so and not say anything, not seek help until they reach that point where you say they're tired or they can't breathe properly,
Yeah.
and they're exhausted.
Yeah. So most of these women, they might mind this problem. We mentioned minding your problems, like when we had heart attacks and all these
Yeah.
kinds of stuff, right? But women generally don't like to complain, I assume. I mean, I interact with many women, but
Christopher.
they generally don't like to complain about their medical issues,
Correct.
right? And they might choose to keep, especially a heavy period, as a private or personal issue, rather than go and discuss it with their doctor. And most times women are actually underestimating how much blood they are losing.
Yeah.
Yeah.
And I think a large part of it is, it's happening every month. It sort of becomes normal to them to an extent. And, as we were speaking before about, minding these issues, and also, they just put down their head and, they have things to do.
Yeah.
And, they just tolerate it because they have other more important things to deal about. And they think this tiredness is just all the things I have to do and all the things I have to get done on my busy schedule. But it's actually anemia.
Yeah.
I always remember, like, this was even before I finished med school, right? We used to do these free clinics. You're excited as a medical student to go and do these things in various areas. And there was this woman who was in flat out cardiac failure because of heavy bleeding from her periods. And she just thought it was, part of her
Part of
monthly
being
cycle
normal.
and a normal
Yeah.
thing for a woman.
Yeah.
So it is important to address these things, and when women start to see problems with these things, or to have conversations with other women and figure what is normal or what's not normal.
So one of the top reasons, because there are many reasons for painful, heavy periods, but one of the top reasons, particularly in our population and across in Africa too, is fibroids. We see it a lot in our community.
Fibroids is one of the most common things, especially in the Caribbean.
Yeah.
Right. And more so amongst Afro-Caribbean women, you'll see a lot of fibroids. Now, most times, and what I see in my clinic, a fibroid can be an incidental finding.
Yeah.
Right. They have no problems, they have no pain, nothing wrong with their periods. They come and they're doing an ultrasound for something totally different, or they screen it and you find a fibroid. And those people, don't worry them, it don't bother them, it don't cause no trouble. But what's causing trouble is when the fibroids are becoming symptomatic, right? And the fibroid is essentially like a benign growth
Yeah.
in the muscle layer of the uterus, right? Now, some fibroids could get real big, and they could grow outside the uterus. Some of them grow inside the cavity, and they could obliterate the cavities, and those have different effects on a woman's reproductive cycle,
Correct.
the abilities to get pregnant, and then just their own overall quality of life, how their cycles actually run.
And you generally see it in the menstruating woman, so
Correct.
the woman that can have periods or bear children.
Yeah.
Postmenopausally, because of the hormone changes, we don't really
Yeah.
see it as much.
But the new thing though is that, yes, in the postmenopausal woman, their hormones will decline.
Yeah.
So technically fibroids tend to go down. But now we have women who are actually using hormone replacement therapy. And fibroids are sensitive to hormone replacement therapy.
Correct.
So it still becomes a little issue that the clinicians have to keep in the back of their mind, in a patient who might have had fibroids and they're on HRT to really, monitor those.
Robbie, we have this new technique. Well, I don't know if it's really new, but it's becoming more popular, let's say. And it's called the uterine artery embolization. Do you want to touch on what that is?
Yeah. So uterine artery embolization is something I'm very excited about. It's something that's very rewarding, has been personally, because it's a novel treatment for fibroids, and it involves no cutting, no surgery. And the word embolization, it means to block the blood supply. So effectively, if these fibroids are being fed by a blood supply, and that's how they get their hormones and all these nutrients effectively that sustain them. If we can block the blood supply to the fibroid, then we can effectively kill the fibroid.
Right.
And that is done via delivering materials from within the blood vessel to block the blood vessel and block the supply of the blood, so the fibroid dies from within without having to remove them physically.
So your technique is via interventional radiology. Now, I know it's not something that's popularly described, so maybe you want to touch on what interventional radiology is.
So, people are probably more familiar with radiologists or radiology. And what a radiologist does is someone who interprets, who's an expert in interpreting imaging, ultrasound, CTs, X-rays. What an interventional radiologist does, he or she is sort of a surgical radiologist. So utilize those imaging modalities to be able to look inside and utilize those modalities to do minimally invasive interventions. So typically, a surgery would be to open up, have a look at what's abnormal, and then fix it. But if we don't have to open up, if we can utilize ultrasound or X-rays or CT to see what's abnormal on the inside, then we access that via minimally invasive entries, needle sticks, wires, that sort of thing. And we can fix some of these things without having to open the patient.
I see
So
some.
hold that thought, Chris, because we're going to go to break. Join us when we come back, where we will delve a little bit deeper on this subject of UAE.
Welcome back, guys. So, before the break, we were digging into what is an interventional radiologist and how we managing these fibroids. But I was going to tell you a little joke. I scroll on TikTok and thing and taking the little memes, right? And you see these radiologists sitting in a little dark room, no light or anything. And then the interventional radiologist is coming like the superstar. He outside in our shades, his jacket, his short pants and things. So, you as the interventional radiologist treating a fibroid is a little different from what is conventionally known as a way of treating fibroids that a gynecologist might do, right? What was your role in performing this procedure for a patient?
Yeah, and I don't like the dark rooms, Chris. I'm afraid of the dark, so I much prefer be out in the sun. So people naturally ask, why a radiologist, why an interventional radiologist, and not a gynecologist? And the whole field of interventional radiology, a large part of what we have been doing is operating within blood vessels, right? We hear about angiograms of the heart a lot, and cardiologists are involved. and you have effectively interventional radiologists doing different parts of the body, doing similar things within the blood vessels. And we are involved in ultrasounds when we assessing the pelvis, and MRIs when we assessing the pelvis, and naturally, when interventional radiology and this procedure first started, it actually started off as an emergency procedure for women who has significant postpartum hemorrhage after they deliver and they're just bleeding and we can't stop the bleeding. So what we did is we would go into the vessels, top the blood flow to the womb, and that would save a life.
Yeah.
And over time they realized that it started affecting the fibroids, and that's how this procedure started off 3 decades ago.
Right.
And over the years, they've fine-tuned a lot of things, particles, particle sizes, what sort of end game we're looking at in terms of finishing the procedure and that sort of thing. So what we do now is we do an ultrasound-guided puncture of the blood vessel within the groin, the femoral artery, and it's effectively a needle stick. There's no cutting whatsoever. And then via tubes and wires, we get into the blood vessel that supplies the uterus and the fibroids, and then we deliver particles within those blood vessels. Just you block those fibroids off. It's not always the easiest to get to those vessels, and that's why we need, usually a fancy lab called a catheterization lab, the same lab that do angiograms of the heart in. So it requires some fancy equipment that we utilize, but the end product is that you have the fibroids treated, the blood supply compromised, effectively strangling the fibroids without having a cut.
Right.
So tell us what the risks of this procedure is, because no procedure is risk-free.
Exactly, and the only people that has no complications are the people that don't do procedures, and I don't like to fool myself in that there are no risks, there are no complications, but it is a low risk procedure, and we always look at the relative to other things. Medicine has evolved and moved towards less and less invasive,
Right.
and with that has come less and less risk. However, we will never reach zero risk. But the whole idea is to reach as close as possible to
Yeah.
zero. Just like any procedure where we do an angiogram or puncture for blood vessel, there's always risk associated with the actual puncture site, bleeding and all of that, forming a hematoma or something of that sort. Very rarely you can develop infection of the endometrial lining, endometritis, and this can be treated usually with antibiotics, but sometimes, and I've actually seen one case of it so far in my career where we've had to remove the entire womb afterwards for hysterectomy because it wasn't being effectively treated. Every so often we would not be able to get to the target and be able to complete it. Again, very rarely, less than 1% of the times. And I would say, in terms of risk of this procedure, is that this is not a 100% success rate procedure. The success rate of this is quoted as 85 to 90%, which means that if we treat 10 women, one to just above one will not have improvement in their symptoms. Not everybody with a fibroid needs treatment for a fibroid, and I want to make that very clear. Right? And you mentioned before how common fibroids are. In our population, by age 50, 70 to 80% of women will have fibroids.
Fibroids for women is like the prostate for men.
Yeah, that's
It
true.
is
Yeah.
incredibly prevalent.
Yeah.
Right? But out of that 70-80% of women who have a fibroid, only about 1/4 to half of them will have symptoms. And this is the
This is what
important thing here.
We touched on the fact it was incidental finding versus symptomatic
Correct, yeah.
patient.
So the fact that you have a fibroid doesn't mean it needs to be treated.
Right.
And I think we need to make that clear. If, however, it's causing you problems, heavy bleeding, painful periods, and amongst the other things that we will talk about.
No, I like to poke the sleeping giant, the sleeping rabbit. But feminists don't come from it, right? But women, I think sometimes too that women might be a little macho, or they might not
Hold
be.
on, what?
Yeah.
Tell me why.
Sometimes women is be a little macho and they don't want to complain about having a heavy period or having a painful intercourse or having really bad pains during these issues, and it's really because of these underlying fibroids. Do you really think that that's the case with women and managing these issues?
Before you go into that, right, let me just say that women historically have not been able to complain, because as soon as you complain about it, they'll say, oh, well, it's just a little period. What are you complaining for?
A period is nothing I want to experience, right? One, not just the pain, but the emotions and all that does go with the period. So, like when my wife having a period, I just go and try to like get a little red mango, get a little thing, butter them up and soften the blow. But,
Soften what blow, Christopher?
the emotional blows that you just have to go through. But not to take away from the point
Right.
that, this is something that women really struggle with.
Yeah.
And sometimes they struggle with it silently,
And yeah.
right?
And that's the biggest problem, because
Yeah.
there's no real outlet for it.
Yeah.
Yeah, and to a large part, women, just shoulder that, and think it's just another one of their burdens to bear. And women more than men are able to chat with their family or their friends about it, but still it doesn't happen. It doesn't happen enough. The women that we see, they often they're really suffering silently. There are women who, yes, anemic, and they just think it's just their busy schedule and their packed life. There are women who quit their jobs because they are afraid that they're going to mess themselves
Yeah.
and embarrass themselves, at the workplace. There are women who go through all of these symptoms, not enjoying life because of something that they think is normal.
Yeah.
Right? It's just part of their burden to bear. And I think it is important that women who experience these things, they start talking to people. They start, talking to their doctor about
Yeah,
it.
come to
Be-
see us. And
Because it's something that is very fixable.
Yeah.
Yeah.
And I think that's the thing. That maybe we as women don't, one, like to ask for help. I will agree with you there, right? But more than that, there's always something to do. You have to fix this, pick up the child, make sure your husband's looked after, make sure the house is in order. So, like you said, there are things to do.
Yeah.
And I think the take-home message that we want to run is come and seek help.
Yeah,
That's what we're here for.
Get it checked. There, we're gonna take a quick break. And when we come back, we'll go a little further. Stick around with us.
Welcome back. Before the break, we were talking about fibroids, how we treat them with uterine artery embolization. And Dr. Rampasad, I would like to ask you, how long does it take to see results?
Yeah, so that's a pretty good question, Elisha. A lot of women would want to know, how soon after if we're not taking it out. And typically, the next period is when you start seeing,
That's quick.
yeah, and because you're blocking off the blood supply. Now, if women are on their period right now, it's already, the lining of the womb is already built up. That will shed and they will have a heavy period. But the next period is when we typically see changes in the heavy flows and other symptoms.
Okay.
Women who have symptoms like constipation and bladder irritation, although the fibroids are still there, they soften immediately. So, we've assessed this from like colleagues of ours who've done the procedure on, and they report from the very next day improvement in their constipation symptoms, improvement in their urinary frequency. The amount of times they have to go to the washroom, that sort of thing, in women who have fibroids that are pressing on, the
bladder,
bowel or the
bowel.
bladder.
Yeah. The other thing I actually was interested in was, does this affect their fertility?
Yeah, and that's a very, very common question that women would ask.
Yeah.
And it's really and truly, it's age related. So what is thought that can happen is if embolization can affect your ovarian reserve. And it really affects women in the over 45 category. But then again, in that age group, there's already inherent problems. It's not as easy to conceive at that age versus younger women. Now, we quote and according to the large trials, between a 1 and a 15% infertility rate.
Infertility, not
Right.
subfertility.
So, subfertility,
Okay.
because there aren't great studies on it yet. Even the randomized control trials, there isn't great or large enough volumes just yet to make pronouncements on these. But if it is that a woman is seeking pregnancy and she is in her early 30s, then we have a conversation about whether myomectomy is a better consideration for her versus uterine artery embolization. But in the younger age group, it's usually between 1 and 5%.
Okay.
And this procedure is like, as you say, minimally invasive, no cuts, no scars, maybe a little choke, a little puncture mark, but nothing big. And essentially, these patients could be out of hospital same day or next day.
Yeah, so in the US, there are same day uterine artery embolization clinics. Typically, we prefer to keep our patients overnight.
Because it's femoral artery.
But no, not so much for that. The big thing about this procedure, it's a painful procedure after the embolization because we effectively strangling the fibroids.
So that's a
That's
good point to make.
So we typically
I
keep
forgot
them for
about
pain control.
Right.
All right. So they're usually on a patient-controlled morphine pump, and then they're going home on painkiller tablets and antibiotics for the rest of the week. But most patients are up the same day, up and about the same day.
I like to be the patient's devil's advocate, right?
Good.
If you really think about it, right? Like you have a pipe with water flowing inside of it, and you put in these beads inside of a pipe with blood flowing in it, essentially. How are you stopping the bead from keeping flowing along the pipe?
Yeah.
So in blood vessels, as they get towards an organ, they become smaller and smaller and smaller until they form a network of very, very small ones.
Nice.
The idea of this is that and in our procedures, we use a slurry of surgical sponge. And the whole idea is as it flows forward, and we have to get to the target 1st. We have to make sure we get to safely the vessels that supply the uterus. And as we inject into that, it gets into these smaller and smaller ones, and it plugs those areas.
Right.
And it effectively becomes stuck in that area.
Nice.
So, when you have interventional procedures or any procedures, we need to think about prophylactic treatment of clotting and versus bleeding, whichever one. What are those sorts of risks in this procedure?
So I'll tell you, we've had in Trinidad, we probably had, it's been done about 20 years now. As far as we are aware of, there's one patient that developed a clotted lung. And since then, all of the patients now, they wear TED stockings afterwards. But unlike unlike surgeries, patients are up on their feet a lot faster. And the risk of clots are usually would be in bed bound. And most patients are back up on their feet within 4 to 5 hours of the procedure. So the risk of clots is much lower, I would say, from open surgery because you're back up and you're mobile a lot faster.
Right.
So like uterine artery embolization, it could almost be seen as a quick fix for fibroids. Is this a value for money type intervention?
I think it is. What I'd say if any of my friends or family has to get treatment for fibroids, I would say this is one of the first options I would explore. Only if they're not a candidate for, then I would look at a surgical option.
Yeah.
You're up faster, and while we think about the cost of the procedure, and it's still less than a surgical procedure. You're up on your feet faster. You're back out to work faster. You're getting along with your life faster.
Right.
And that's the benefit of minimally invasive procedures as well.
Yeah. The values and what the patient actually values for themselves
Cost is
beyond
nothing.
beyond the surgery or the procedure itself.
So, do you then think minimally invasive procedures are compromising or in place of holistic care for patients?
And I think we need to always realize that these things can't operate independently.
Right.
Medicine has come to the point of collaboration
I
and
agree.
working together with teams. You know, we have more and more specialists now, but what specialists are is you know a lot more about less.
one thing,
particular
Less areas,
topic. Yeah.
exactly. And then whenever we have complex patients at medical associates, we rely on each other
Yeah.
because that's how it works, right? We have people who are experts in a particular area, but you can't be expert in everything. And I think we have to realize as doctors what we don't know as well. And you have to take the ego out of it, and you have to realize what you're good at and what you're not good at. But there's always benefit in working with a team, and we have to push the team approach and the collaborative approach always.
Well, that's why they call it a multidisciplinary team now.
Exactly.
Yeah.
You know, do you see, patients becoming more open to wanting this type of procedure rather than opting to do a myomectomy? You know, if they had to choose.
Yeah, and you know, if anybody has to have an option, you know, you're not gonna choose the most invasive option as your first choice, right? Sometimes we need surgery. There's no doubt about that.
Yep.
But if there's an option where you're a candidate for uterine artery embolization and you don't have to get cut and you have to recover from a surgical wound, it is always lovely to have that option.
Right.
You know, somehow a large cohort of our patients are self-employed women who don't have the luxury to take time off,
Time off, yeah.
right? And we've had women, I'm talking about women with businesses of their own, and they've been back up in their businesses 2 days after the procedure, right? And you know, some women say just, I can't afford to be down for weeks. You know, my children need me, my job need me, you know, all of these things.
And so, majority of these women are really followed up by gynecologists because this is a predominant gynecological problem. So, how does the relationship with their gynaes work in these cases?
Yeah, so all of our patients are co-managed with gynecologists. There's always benefit in collaboration.
I agree.
There are things that, as an interventional radiologist, we are not great at, and vice versa with the gynecology team. So all of our patients, before we do a procedure, it's either we work with their gynecologist, and for the women who come to us directly, who have not seen a gynecologist, we get a gynecologist involved, and we have a great team of gynecologists at Medical Associates.
Yeah. Great.
I agree.
So, unfortunately, this has been great, by the way, and I'm pretty sure that a lot of women are going to appreciate this topic. But unfortunately, that's all we have time for today. So we do appreciate you coming on board, and maybe in the future you'll come and talk to us about some of your other techniques that you use for other conditions.
It would be a pleasure.
Great. Well,
Thanks, Ravi.
thank you very much for watching, and we hope that we will see you again very soon. Don't forget to check us out on our social media pages. If you've missed out any of this episode or any of our previous episodes, you can watch them on Facebook, Instagram. I think you could probably see on LinkedIn as well. So we'll see you next time. Take care.